Hello, everyone from Montreal. My name is Kirsten Johnson, and I am the president-elect for the Canadian Association of Emergency Physicians, and it gives me great pleasure to introduce the first CAEP National Grand Rounds. We have been talking about this internally at CAEP for at least the past year, and now, due to COVID and the success of our 9 CAEP COVID town halls, it has finally become a reality. And what makes this inaugural session even more special is that it is occurring on what would have been CAEP's conference week in Ottawa. CAEP has been holding conferences every year since its first one in 1980 in Vancouver, organized by a certain Dr. Wayne Smith, who worked where I work, the Royal Victoria Hospital in Montreal, and Dr. Powell, who works at Foothills in Calgary, which is also where I went to medical school. The second annual conference was held in 1981 in Montreal. We have not missed a year since, so 2020 has left a hole, and hopefully one that will create something new, like the CAEP National Grand Rounds. Our conference this year was to be held in Ottawa with the theme, Better Together, a rather appropriate theme for the time we find ourselves in. The tragic death of George Floyd has reinvigorated a sense of urgency on bringing us together to address the systemic racism and discrimination in Canada and the world. So because you can't come to our conference this year, we thought we would bring the conference to you. Tonight, we are so fortunate to have our conference plenary panel join us to speak on important topics concerning advocacy, locally, nationally, and globally. I'll start by introducing the moderator for tonight and then let her take it away. But before I do, I should mention that our hashtag is CAEP Grand Rounds, and we'll be continuing to offer these on a monthly basis, so please do continue to join us. All right, Dr. Heather Murray is a professor and the deputy head of Department of Emergency Medicine at Queen's University in Kingston. She is an award-winning medical educator and is passionate about knowledge translation, diagnostic reasoning, and evidence-based medicine. She creates innovative and collaborative learning opportunities for healthcare providers at all levels and advocates for authentic connections between learning and medical practice. And she is the perfect person to moderate tonight's session. So without further ado, I'll hand it over to you. Off you go, Heather.
Well, thank you very much. It's super exciting to have the opportunity to be part of CAEP's inaugural Grand Rounds. And what better topic for our national advocacy voice than a session that talks specifically about advocacy. So the word advocacy comes from the Latin advocare, which means to call out for support. And we advocate for patients every day on an individual level, but the kind of advocacy that we're talking about tonight is the kind of advocacy that influences change, gathering support to influence change at a higher level. And that's really looking at advocacy at the department level, at the community level, and nationally. And so I'm really excited to have 4 Canadian physicians with track records in different areas of advocacy talk to us today. And I'm gonna just stop and let them introduce themselves to you so that you can get a feeling for who our people are and what they're all about. I'm gonna start with Lisa Richardson, Dr. Richardson.
Hi, my name's Lisa. I'm actually an internal medicine specialist, but it's fun to be here with all of you Emerge docs. And I'm an Anishinaabe physician and do a lot of work related to Indigenous health. I'm Vice Chair of Culture and Inclusion at the University of Toronto Department of Medicine and strategically Indigenous health for the Faculty of Medicine, co-chairing the Royal College Indigenous Health Committee. So, and I'm a mom. Miigwech.
Excellent. And I'd like to invite Dr. Carolyn Schneider to introduce herself, although I suspect she needs no introduction.
I always need introduction. I'm Carolyn Schneider. I'm the chief of the emergency department at St. Michael's Hospital, and am just really happy to be here. I've focused much of my academic work on how we can work specifically with youth who are affected by violence, and did some work in Winnipeg around that, but continue to broaden that focus now to many of those who experience a disadvantage who come through our emergency departments.
Great. I'd like to have Dr. Courtney Howard introduce herself.
Hi, I'm Courtney Howard. I am an emergency doctor in Yellowknife. I live in Yellowknife on the Chief Dry Geese territory, traditional home of the Yellowknives Dene and North Slave Métis. And I specialize in climate change and environmental health because we're kind of melting up here. So I'm excited to talk to you about the kind of advocacy we've been doing over the last few years.
Awesome. And last but not least, Blair Bigham, Dr. Blair Bigham.
Hi, my name's Blair. I'll be finishing my emergency medicine residency in a couple of days and then heading to work with Dr. Schneider's team at St. Michael's Hospital. And on the side, I finished the Global Journalism Fellowship at the University of Toronto back in 2016. And since then, I've been reporting for Canadian media on health and science. And since about last year, have been looking into how misinformation and disinformation spreads online and affects public health outcomes.
So just to give you some idea about how we're going to run this Grand Rounds, each of our panelists is going to do a 10-minute presentation with slides that they'll share from their computer. And then we're going to stop and have some questions among the panelists. If you have questions that you want to bring forward, please tweet them using the hashtag CAEP Grand Rounds, or there is a phone number that you can text them to where we will be accumulating questions that come up as the time rolls out. And we're going to take time after all of our panelists have spoken to bring in audience questions at that time.
Ani, thank you, everyone. It's such an honor to be here. And I really wanted to acknowledge, as Dr. Johnson said, the time that we're living in right now. I have to admit that in preparing for this presentation, Nothing About Us Without Us, and thinking about advocacy, the advocacy work that I do is for Indigenous peoples, but work closely in solidarity with the Black community. And I wasn't sure I'd be able to do this. It's been such an emotional time, and I want to. I'm thinking about all of the members of the Black community who may be in our audience right now, standing in solidarity with you as we live in this unprecedented time, which I hope will bring about significant change. I'm going to put my timer on too, so that I could have a tendency to speak for a long time, as we do as Indigenous folks often. So wanted to acknowledge that I'm on the traditional I'm here in Toronto, but it's the traditional territory of the Mississauga of the Credit and the Haudenosaunee people. Traditionally, going way back, the Huron people were here, Seneca, and there now are people from across Turtle Island who are living in this city known as Toronto, which is also called Takaranto. The images that I'm using are by an incredible illustrator named Chief Ladybird and Selena Mills, and I have permission to be sharing them with you. So enjoy. We're speaking for a short time, and we're hoping for this to be really interactive. So I'm going to introduce myself and the work, and I'm going to talk about key principles for advocacy. And this is really situated in advocacy with our Indigenous communities, but I think you'll find that it can be extended out to other communities who are structurally marginalized. And hopefully some of these key principles you'll be able to take home with you and apply. So when we come together as Indigenous peoples, we always introduce ourselves. So that's why I was really pleased when Heather Murray said, I'm going to let you do that, because that's the way when we traditionally gather, we would do that. And that's our way of recognizing our name, possibly our clan, our ancestors, and our connection to a particular land base, as well as the land that we may now be visiting on. So as I said, my name is Lisa Richardson. I'm a mixed blood Anishinaabe, so I'm European on my dad's side, Scottish primarily, and Anishinaabe from a community called Shebanoning, also known as Killarney on my mom's side. There's a lot that I could tell you about our community, and we don't have time to go into that. But I think that the idea of doing an introduction is that we, especially when you're thinking about partnerships and working with communities where They may not be traditionally, they may not have been as comfortable with healthcare or academics or research. The idea of recognizing where you've come from, what your situated perspective is really important. So it's locating yourself. And it also leads to the next piece, which is critical when you're working with our communities, and that's called reflexivity. And if you were to say that, if you're going to one of our communities and say, oh yeah, I'm going to be really reflexive, people would, I don't know, that it's something that I would throw around as a term, but reflexivity is really key right now. We're seeing a lot of statements coming out of our institutions and our organizations in solidarity with the Black community right now. But reflexivity, I posted today on Twitter about how all of our institutions need to be reflexive. And that means you need to have a critical look at who you are as a person, what biases you have, what privileges you have, what experiences, background, culture you have that you bring to all of your interactions. And similarly, at the institutional level, you need to do the same thing. So at the institutional level, that means thinking about, well, who's on my board? Are they reflective of the community that I'm serving? Who are in the senior leadership roles? What proportion of the panel that we're on, for example, represents the diversity of our medical student body? And so we spoke actually before this started about how we are all now a white appearing panel. And in this time of systemic racism, where it's really bubbled up and come to the forefront, how do we actually make these intentional decisions about composing panels, about who we're inviting as speakers, about who we're nominating for awards, et cetera? So that's what I call reflexivity. It's actually a term that comes from the social sciences. So the key idea around advocating for our communities, Indigenous folks, you may say, well, there's an access to water problem, there's an access to broadband problem, there's an access to vaccination problem, cancer care, who knows what it may be. But really, you have to step back as a clinician or as a researcher or a scholar and say, what is it that's meaningful to the community? So my good friend Evan Adams, who was the medical director of the First Nation Health Authority, used to sums this up really well when he says, if you think that a community needs a health center and you go into that community and they say they want a spa, you have to be ready to build a spa. So we have to be listening. And the three principles that come from Indigenous research methodologies that I think are really important when you think about working with our peoples are respect, reciprocity, and relationality. So what does that mean? Respect means that you have to ensure that the work will be honored and respected by your own people. And this is a quote from Dr. Sean Wilson, who's a Cree scholar. And he actually wrote for Indigenous scholars. And so that's why the quote says, will be honored and respected by their own people, so by our own people. But I think it's really important to think about if the advocacy project or work that you want to do, is it relevant and meaningful to the community? And that means not you going to a community with an idea. It may mean you go into a community and say, hey, here I am, and I have this skill set. I'm an emerge doc. I actually run Air Orange and in charge with ambulance transfers, for example, here in Northern Ontario. Are you having any issues with that? Let's talk about it. So the second principle is that of reciprocity. And reciprocity means that you're not going into a place and establishing a partnership and working with a community where it's a one-way exchange. Reciprocity means there is sharing of ideas and sharing of benefit in whatever project is decided upon. And in fact, this is so strict in the research realm that in many communities now will actually not even allow researchers to enter unless they know there's a clear reciprocity agreement. I think when one's working in partnership and meaningful partnership, and you'll notice that we're no longer using the word engagement. Engagement is a 1 or 2 or 3 time meeting. Partnership means being alongside a community every step of the way, in the good times and in the bad times. But if you are entering and choosing to work alongside as a partner, you need to engage in deep listening. So hearing with more than your ears, being reflective, being non-judgmental, thinking really seriously about what you're seeing and hearing, not judging, not jumping to conclusions about what you think the solution will be. Because partnership in our communities usually means that the answer comes from within the community. And responsibility is that whatever you're told and whatever you hear, you hold carefully and you honor. And you're responsible to honoring that relationship. And Sean Wilson actually talks about another really important concept, which he calls relational accountability. And he talks about building a relationship with whomever you're partnering with. And this could be in the urban setting, it could be the rural and remote setting, it could be with a community health center, for example. Being attentive and responsible and accountable to that partnership, so that when things get bad, you don't walk away. You say, hey, let's sit down and talk about this. I'm sorry for what happened. I want to learn from it. And let's make sure that we continue to grow and build this relationship, just as you would with any other partnership, friendship, etc., I will add. So I think it's being accountable to that commitment. And this is very unusual because in a lot of biomedical and and more Western models, we're really not focused as much on process. We're focused very much on outcome. But we say in our communities, the relationship and the process is a really important outcome. So how did that relationship go? How committed were you to it? The concept of allyship, this is my colleague and good friend whom I work a lot with, Dr. Ayelet Cooper, does a lot of work around allyship. And I think allyship's really important right now. I think there are a lot of people there's a lot of work that we can do as allies. And an ally is someone who's not in the group experiencing discrimination. An ally supports the rights of marginalized people and acts when they're facing discrimination. And in medicine, the person who needs an ally could be a patient, a family caregiver, a colleague, a hospital employee, or a trainee. And depending on the situation, we can be an ally, but there may be contexts in which you may need an ally. So it's there are shifting positionalities around allyship. I think what we're seeing right now, particularly in response to the racialized violence and against the Black community, is that there's a lot of concern that the allyship is, quote, performative. So that, are you as an ally willing to really go out on the line and change your organization, change your institution, say, you know what, no, this panel's no good. I need to see different representation here. How much of a risk are you willing to take as an ally? And I think the other piece around allyship that's important in the context of partnerships and nothing about us without us is you may observe a really egregious thing, but it's really important, and you're going to intercept a moment of racism, for example, a racist encounter or comment, but it's really important that you're actually doing that with the support of the person who's experience that, so that you're not charging ahead with the idea. In the same way, going back to that concept of respect and reciprocity and really listening, one needs to do the same in allyship. And anti-racist practice, also a key component and really important in advocacy with our communities. So Elizabeth McGibbon and Josephina Toa, who are out in Halifax, wrote this incredible book called Anti-Racist Healthcare Practice. And they talk about the ways in which anti-racist practice can develop. And they say, you see the path from stereotype to oppression, understand and connect those paths of oppression to policy, and you action for social change. And I think that's what we're all wanting to see a lot more of right now. So lastly, in my last, I'm 59 seconds over, sorry, Heather, I just wanted to say nothing about us without us in the advocacy realm for me involves, I've talked about community, and it implies, I'm sort of implying going out into community. And I want us to look inward at our department, at our program, at our med school, at our faculty, at our institution, and say, what can we do within our institution to create space? Because nothing about us without us means that we need us, we need Indigenous, Black, other people of color, other gender minorities within, and et cetera. Sorry, I haven't listed everything. This is primarily a talk about Black and Indigenous folks. We need to really think about how we change our institution. And I've written about this in the Indigenous context and follow up to the TRC. It was a report called Wise Practices for Healthcare Transformation, but we need meaningful partnerships. We need recruitment and retention of Indigenous peoples and Black peoples across the organization to the board of directors, to the senior leadership team. We need cultural safety and anti-racism education. We need safe processes for people within those institutions to be able to debrief racist or culturally unsafe experiences. And we need really robust outreach and mentorship programs so that if your organization is saying, oh, we don't have anyone who's actually qualified right now to become the physician in chief in your department, you have to say, well, I'm going to identify a whole host of people who we will mentor and support in order to get into that role. So lastly, I always end my presentations with this quote by Marlene Brandt Castellana about self-determination, which I think is really summarizing nothing about us without us. Fundamental to the exercise of self-determination is the right of peoples to construct knowledge in accordance with self-determined definitions of what is real and what is valuable. Miigwech. Thank you, that's it.
So I want to pick up just on what you were saying at the end. Can you just expand a little bit on the concrete things that we can do within the locus of our control as emergency physicians? You talked about cultural sensitivity and anti-racism training, and I'm wondering if you can spend a little bit more time there and just tell me, other than reading the book about anti-racist healthcare practice, which I now have on my reading list, what can I take to my department tomorrow to move forward?
I mean, so we need everyone to become allies so that when you observe a moment of racism towards a patient or towards a colleague, then you are comfortable with and have the language to interrupt that. So you need to do training so that people have those skills and those abilities. You need to look at the leadership of your department and say, who is represented here and who is not? And if you have gaps, and you don't have BIPOC, so Black, Indigenous, people of color, then how can I recruit? How can I support the mentorship and development of those people? When you have those instances of racism that may occur in your department, that do occur, you need to have processes where people can safely discuss, debrief, and where the institution will learn from them, but all the while supporting the person who experienced that. Because what often happens classically when you encounter a moment of racism is the institution dismisses and, oh, I'm sure they didn't mean it. There are a whole bunch of classic responses, right? It's an unconditional, how do we support the person who's experienced this? And then how do we go through a meaningful way to review and to keep track? That doesn't have to involve the person who's experienced it, but so that you are actually making those changes and reporting on them in exactly the same way we would a QI and patient safety incident, but with a different obvious focus and with different experts who are supporting this. You need incredible expertise to be able to debrief anything like this. So you need a dedicated personnel, for example, person in your office, in your hospital who could do so.
Right. So it's its own thing. It is enshrined as an institutional value, and that training and that support is as important as any other QI practice that we would do in an institution for any other kind of error in care.
You know, the thing is that health equity is a part of the patient, is a part of patient safety. And it is never, but we've never, and high quality care is meant to be equitable care, but we actually haven't seen that action. We haven't seen action on that in a meaningful way. We haven't seen reporting on breaches of safety as a QI incident. You know, there are lots of ways in which I've been trying to push the QI and patient safety movement to go there. I think it's just been, it's a new area, but what we do know that racism affects health outcomes. There's lots of evidence around that, and we need to start dealing with these incidents in the same way we would any other safety incident.
I want to pivot to Carolyn, and as an emergency department leader in Toronto, you must have some thoughts as you hear Lisa talking. I mean, I know you're both in Toronto, but what are your thoughts here?
Well, I absolutely agree with Lisa's approach about needing the structures in place, and I've just learned a lot from many of the things she's just said about thinking about my own practice. One of the things that I want to implement as we go forward, and actually was all ready to before COVID, and we will sort of move forward on this, is that when we think about M&Ms and look at unfortunate outcomes in our patients, we actually also ask the questions about where are implicit biases, may have affected that patient's care, but also that we can learn how to look at the systemic racism that is part of our system that we practice within, and how that affects the care and the outcomes that we sometimes see and talk about. And so I want us to start feeling confident and comfortable with that being a normal process to go through every day. When we walk into a room, how do we check our implicit bias? How do we think about poor outcomes within the context of the system we work with, and as well, and how can we then use those as opportunities to advocate?
I want to turn to Courtney. Working up in Yellowknife, I'm sure you have a ton of interaction with Indigenous patients. Do you have the sorts of systems that Dr. Richardson is referring to in your smaller community hospital? Is there that kind of training and debriefing of medical error in that same way?
You know what I think has made a huge difference is that we have an Indigenous nurse on almost every shift. So I was thinking about this as you were speaking, and I actually recently had a conversation with a graduating medical student who is Indigenous, who had a horrible experience when she actually called out racism in a clinical environment and then essentially got targeted. She basically got failed for that rotation without any, she'd passed all the exams every day. She'd gotten a good reputation, like a good evaluation, but it meant that she missed her graduation. And I was thinking about, she was telling me what the remarks were, and that was the moment where I actually realized I remember hearing remarks like that when I was in more Southern Canada, and it made me realize I haven't heard one up here in a long time. And I think it's because we almost always have there's always Indigenous nurses. And so I think, a really big part of this, I think that what you mentioned there makes a lot of sense, but a huge part of this is us making sure that we support in a structural way Indigenous physicians, Indigenous healthcare providers, because it just happens after that. The power structures change and norms change.
So just turning to Blair before we move to Carolyn's presentation, you just finished residency, and I'm wondering if you had anti-racism training during residency or cultural sensitivity training during residency. I mean, have we improved our training structures? I'm curious to know your experience or thoughts here.
So I haven't received any formal training. I'm sure it's in the curriculum formally somewhere as a tick box, but nothing that I can remember. But certainly I would say that I got an informal education from my peers. I think, and it's difficult for me as a white male to truly understand how much privilege I have and how that's affected my journey. But I think that everybody coming up through medicine now in residency is much more aware of language and inclusivity. And I do think that there's a bravery amongst younger doctors now to call out people when they hear language that doesn't sit right with them. And so I think that there's an informal training that goes on amongst residents that hopefully sort of heralds a bright future, especially when we look south of the border at what's going on there. And just listening to everyone speak, one of the things that came to my mind was what would have happened if George Floyd didn't die? And it just, I think, makes me realize how reactive we are as well-intentioned advocates, and how that is admirable, but perhaps not the most strategic. I think often we wait until we have to advocate before we do. And so everything that's been said now just has the wheels turning in my mind about how we can lend our voices sooner and louder.
Yeah, okay. And Lisa, just one more question, and that's just in this area of training. What message do you have, I guess, to CAEP and to our residency programs about emergency physicians and their training programs and what we need to be doing better, more?
Yeah, I mean, I'm going to put on my hat as the chair of the Indigenous Health Committee at the Royal College and let you know that for the FRCP Emerge, there, there will be mandatory accreditation requirements coming related specifically to Indigenous health, but they will include practice. They include anti-racist practice and teaching around cultural safety and anti-racism. And similarly, the CFPC has done the same thing. So I think to build towards this and understand that this is required, I think the point the point about the experience of as we have 24 Indigenous med students starting at U of T in the fall. Black medical students. We have 4 Indigenous students starting at U of T in the fall. So we need to create really safe environments for those learners. We need to have strong and important mentorship for them, and we need to guide them and allow them to do whatever they want to do. And if they're interested in academic medicine and leadership, so that they can help to change these structures, in our university settings, or if they're interested in leadership and want to do it at their local hospital settings, support that leadership development as well.
Okay, well, thank you. That was really interesting to listen to, and certainly I have some concrete takeaways noted down for myself and for my own department. I want to turn and hand the screen over to Dr. Schneider and her thoughts.
Thank you. I'm going to start just chatting for a moment or two before I start my slides. I want to thank you all for inviting me to this discussion. And I wanted to say I've spent a lot of time thinking about what it means to be an advocate, and that's changed over my career. So I'm now into my late 40s, and it's different than when I first finished medical school, which is different than when I started residency or finished a residency, etc. But I find that events like COVID and the structures that we work within and how different groups are treated and cared for differently, as well as George Floyd's tragic death, are often reminders for us to continually circle back to examining our own actions, both our own individual roles within the system, but also the system that we practice in. Over the past few months, the importance of effective advocacy has been really amplified. And I'll be spending a lot today reflecting on my experience advocating and leading a department in the midst of COVID. And so while I think of the importance of advocacy from that standpoint, I really feel that many forms of ineffective advocacy have also been amplified. And I thought I'd reflect on some of those as well. I realized I forgot to share my screen now. There we go. I follow many people on social media, but in reality, I'm not a huge fan of social media. But I personally stay on it for there's a few reasons I stay on it, but one of the key reasons I stay on it is that I find it allows me access to essential voices of people who have lived experience that aren't often sitting at the tables that I get to sit at, that I have the power and privilege to sit at. And they're often the ones with true expertise. They're not my only source of information. I learn a lot from patients at the bedside, and I also try to be out in the community to learn from people within our community as well. And that's all a part of relationship and learning. But social media for me does often provide me teaching and regular reminders of the absence of key people. And I guess that ties into what Lisa was talking about not making decisions without the voice of people who are most affected by it. Next slide, please. I mentioned, however, that I don't love social media. And I know that not all share my view, but I find myself at times thinking it is harmful. Last week, I have a friend named Roberta Newman. She's a cultural historian in the US, and she shared her struggle with the performance of liberality. And I feel like Twitter is an echo chamber of these voices. So many people who actually say things, they perform on Twitter, but don't act. And to me, that has been very highlighted in COVID. And as someone trying to enact change on the ground, I find it very frustrating at times to be on Twitter. There are a lot of people who present themselves as experts, but don't have expertise in a certain area, and they don't make the effort to actually make the change. There's a lot of finger pointing without getting on to do the work. We hear them in the media, We see people tweet voraciously, but when you're on the ground level, they're not there. And to me, that really speaks to the importance of us making sure that our voice is more productive. Next slide. In the emergency department, I think we actually do have a magic 8-ball. We actually could have told leaders a year ago where the cracks were that were going to widen during the COVID pandemic. We knew them well. None of us were surprised by the impact it's had on the homeless communities, in nursing homes, and the vulnerable and low-income communities. And for years, we see those disparities because they are who land on our doorstep because of the systemic inequities. Many of us try to use our voice at times, but I'm pretty clear that we haven't acted effectively enough on that. And so much of the last few years of my career, I started to think about how I can use my role as my powerful role as an emergency physician, and now in a leadership role, to try and enact some changes. I do continue on a massive learning curve, and I'm going to share with you after my initial pontification that I've had a lot of personal failures. And so even within the last 4 months, I've had some failures, but I've also had a few achievements. So I wanted to share those concrete examples. So reflecting on this, I would say that as much as I talk about that voice without action, I probably don't always share my voice as often or as effectively as I should. I'm so conscious of being paralyzed by my own personal need to always follow my voice with action that sometimes I'm too quiet in my response to great injustice. And I don't mean that necessarily on a day-to-day level, but when big things happen, I struggle sometimes with knowing what to do right then and there. I'm also learning that I need to find a way to better keep people accountable, but while remaining productive. And so during these last 4 months, I've learned not to finger point publicly, even though sometimes that's what it feels like would be the best way to hold people accountable. I'm learning to do that maybe in a more sneaky way, or figuring out who gets things done and going to them when it needs to get done. And at times that can be frustrating. But I've also learned that there have been times where I've pointed fingers or at least expressed my disappointment in things, and it's resulted in me being left off the table, where I may have in fact been able, if I'd done it a bit more diplomatically, I may have had a more positive impact with the groups that I want to advocate for and with. And so that's been a learning about how to do that in an appropriate, balanced way, while still maintaining the need to take the risks when they need to be taken. I'm also learning that although I believe big changes need to happen and I continue to need to advocate for those, I also need to be okay with small achievements as an advocate. And so in the midst of COVID, we at St. Michael's Hospital have really seen the impact on the homeless community. At St. Mike's, we've cared for over 650 people who are experiencing homelessness, with over 2,700 visits in the past 10 weeks alone. We've converted our waiting rooms, our multiple rooms, storage rooms, our old trauma room, any potentially available safe space in our emergency department as a possible space to isolate patients who are experiencing homelessness while they wait for their swab results. Some have waited days. We've hired extra community support workers, social workers. Our internal medicine colleagues have been incredible partners when we hit unsafe numbers in our emergency department. And none of us feel that the acute care setting is the right place for them. And yet, due to the ongoing patchwork response that is occurring in this crisis, we continue to be the last resort, and even at times the only resort for this group. This is an example of a crack that we've seen widen. So an example of a small achievement that isn't mine, but that I had a part in. In the late afternoon, if you want to switch slides now, please. In the late afternoon on Saturday, May 9th, approximately 20 patients were sent in from a local homeless shelter. Now, the photo I've got up right now is actually of Seton House, and it's not the shelter that I'm speaking of that day. I have a great relationship with the people at Seton House. Seton House, for those of you that aren't from downtown Toronto, is the largest homeless shelter in Canada. it has, on a normal day, it can have about 700 people. At times it's gone up close to 900 people living there, all those who identify as men. So on the late afternoon on May the 9th, it was a Saturday, we had approximately 20 patients sent in from a local shelter within 1 hour. They had been identified as close contacts of a positive case that they just found out about. And it hit us at a time where we were already almost out of isolation space in our emerge. When I called the shelter staff to get more information, it was so very clear how vulnerable they felt. They all needed isolation space, and the vulnerability of the shelter worker on the phone was so very clear. Their voice quivered, and I spent a significant amount of time trying to express how much I actually understood their vulnerability and why they'd sent in their client. I eventually ended up working quite closely that evening with their shelter manager as we worked through the logistics of managing the inflow. The patients were also very overwhelmed. They'd been told they needed testing, but not that they would subsequently need 14 days of isolation. Some had very complex needs that couldn't be met at an isolation shelter site that we have in Toronto, and others were students or had jobs that they needed to keep. Many of them told me their stories and their frustrations of finding this, and these are the stories that really need to be at the table. Our emerge team worked with our assessment center to get them tested, our social workers, our microbiology labs to try and get their swabs prioritized, with the GIM staff, with the isolation shelter staff, with public health. And we made it through again. Next slide. But this was the 9th time in 3 weeks that we dealt with a similar situation. Each time was like a mini code orange. And we narrowly would scrape by, ending with great frustration with our broken system. And in those 3 weeks, or in fact in the many weeks prior to, I'd been part of multiple meetings, many of them by Zoom, sat on multiple quote unquote tables where we had 40 people talking about a coordinated response and yet to see it. Many tools and pathways were discussed, and some have been made, but few make it down to the shelter worker who's on the front line or having been developed by that front line. Next slide. And so this time, after our mini code orange was over, I decided to hold a debrief because I reflected on the fact that after each one of these, I felt just as exhausted as I had at the end of the Raptors parade, where we saw hundreds of people come through within a few hours. And I invited 7 people that I'd met at these various big meetings that I knew would listen and had enough power to make some change. And I invited Jake, the shelter manager, who I spent a good part of my Saturday evening with. And we ran it just like we'd run a debrief after a code orange. I made a clear rule that no fingers could be pointed, and this was meant to be a place of safety and change. We walked through what happened and why, what we thought was supposed to work but didn't, and how it felt in that moment, and how we would change things so that people like Jake and shelter workers who work with him or like him would have a clear pathway for when this affects them. And we could try to make this terribly inhumane issue a little bit more humane. And by the end of the week, the public health staff that were on that call and the shelter team that was on that call, the people in power, worked to develop a shelter response team that was finalized and in place. And now 3 weeks later, we've yet to have a mini code orange. What was most important to me about that moment, and frankly most effective, was Jake's voice. It wasn't mine. I only had the power to bring some people to the table. It was empowering for him to tell his story and that of the other shelter workers and what they've been dealing with. I could only echo that this was the exact same story I'd heard the last 8 times. And to hear his ideas of what would work and ensure that people who could make that happen heard it too. So my next step is to try and find ways to ensure that the people who are experiencing homelessness are now at those tables. And I've come to realize that this is a big, big pot I'm working within. I'm not going to be able to fix the big homeless situation myself, but I can be part of some small changes as we go and continue to advocate on a larger system basis. So to summarize my thoughts as an emergency physician who is seen as an advocate, and I'm always challenging myself to be a better one, I am very clear that we can't just be a voice. We have to follow it with action, both personal and within the system. We need to acknowledge that we are very privileged and that we are privy to the major cracks in the system, and we have a powerful voice and responsibility to advocate for those changes. I'm still very much on a learning curve as an advocate, and I'm trying to find the balance between using my voice effectively and acting on it. And I also continue to be fueled by opportunities to use my power and privilege to invite and ensure really that the people who are most affected, those with the true lived experience, are at that table too.
So I'm interested to know, Carolyn, how do you think you can bring those people to the table? Because as we think and talk about advocacy, I think it's difficult for some populations to partner with people. The temptation is to advocate for, and bringing them to the table, I mean, is a great potential solution, or at least first step in that direction. How do you hope to achieve that, or have you achieved it?
So Heather, I actually think that I probably learned this mostly in Winnipeg, that if we get out of our own big walls and our own big structure of a hospital and develop those relationships, and Lisa really speaks about that, the importance of a two-way relationship. And that takes time, and it's an important piece, and to be there when things are bad. That when the opportunities come that you see to bring people to the table, I do find that that my community partners are often quite happy to be heard, because they don't get heard enough. So a big part of it is bringing them to the table and ensuring that they are acknowledged for their contribution in many ways. And it's not just a voice that comes to the table and then goes away. It's a voice that means you're part of that table. And so that's a big part to it. So I think probably the first few times I'll tell the story. The first time I truly can remember getting out into the community in a valuable way was when I was in Winnipeg and working within the hospital structure to look at ways we could develop programs for youth who are injured by violence. And I went to a community meeting, and I remember the first time I went to the community meeting, there was sort of this question as to why I was sitting at the table, and I just said, I'm here to learn. And I stayed quite quiet, and then afterwards was introduced to a few people who then I had coffee with. And then the next time I went to the meeting, it was at a different community center. And at the end, I happened to stand up and pick up the coffee cups on either side of me and went to wash them. And later, that was the story where I was told was they figured I was okay because I cleaned other people's coffee cups, which is such a simple story. But the reality is I was just part of that group at that moment. And it's an interesting story because I never thought anything of it. My mother taught me to pick up the cups on either side of them and cut and clean them too. But it speaks to the importance that, I actually felt a little nervous the first time, and I've learned that I can be there in partnership with them, and that we're welcome when we show them the kind of respect that we would show each other anyway. So I guess that's the piece, is I think it's actually not so hard to get out.
I actually want to turn to Lisa and get her thoughts about Carolyn's experience with supporting patients with housing challenges through this COVID epidemic. And you must have had some thoughts listening to that story about your own work and how there's overlap, perhaps.
So I was definitely thinking. So yesterday we were actually out at one of the tent sites and testing 101 people wwho were living in those tents. They'd left the shelter system because they felt uncomfortable there because of the risks of COVID. And we heard things like, wow, this is so different from our usual experiences going into institutions and You're so kind. And thank you so much. And it was that the lesson for me was taking care for people who have been excluded by our institutions. Taking care into the community is a really important way for people to access care. And, you know, what a different experience to be surrounded by your, you know, colleagues, to be in a familiar environment. Like getting a COVID swab is actually, for anyone who's experienced trauma, as many people who live on the street have, or many people in our communities have, a swab into your nose is actually extremely invasive, right? No matter where you are. And so when you have to also be in an institutional setting where you've likely been mistreated at some point in your life, I mean, so much of the evidence would support that, then it's very challenging. So I think the model that we're seeing more and more of for why are we asking structural people who are vulnerable based on our systems to come into our systems? Why aren't we actually working with them, co-designing and actually meeting people in their places? You know, obviously the issue I'm also really, it's problematic to me that I was having to support people who are in tents when we should be advocating for houses for them. And certainly that's been another part of the work that we've been doing. But it was really powerful because we had an elder there, and we had, you know, people could smudge, and this was not just an Indigenous community, but there are, you know, Indigenous peoples are overrepresented in those who are living rough. That's well known. So.
And I think that point is well taken for emergency physicians. You know, we're very comfortable in our environment. Very few patients are. In fact, even privileged members of our communities who come in for care in our departments are often terrified and overwhelmed. And if you take that to more vulnerable populations, I think maybe we need to just upend the idea of people coming to us for care and look a little bit differently at the way we deliver care and the locations. I think that's a really great way to end that particular segment. And I want to turn the screen over to Courtney to talk a little bit about climate change. So.
Thank you. I've really enjoyed this so far. Thank you so much to everybody. I was really thinking about what everybody was saying about going into other people's spaces. And I think that's been really, really key for me. And that's part of being uncomfortable too, you know? I remember going for a Chinese lunch at the Yellowknives Dene office, and it was all very different. But those are the relationships that I've built that, you know, these are very much my community members now. And so I think it really does have to go with, you know, going into other people's spaces. Oops, sorry, I got the wrong title there. But in any case, thank you for having me. And what we're going to do is we're going to reframe health. And this is sort of a picture of, you know, a land, a field, and it's not something we would really think about often as having anything to do with health. But, you know, this is where food comes from. And so we, you know, went to school for a very long time to learn how to work in the emergency department. And I am very proud of the work that I do there. And I think it's important that we take a look at all of the things that need to happen correctly in order for us to be able to do that work. So this is a slide that I drew with my grade 7 art skills, and I have a graphic designer making a slightly different one, but really the cradle of all of this are the ecological determinants of health. So things like oxygen, water, food, fuel, ozone, and when all of that is stable and produces enough resource for us, we can start to do things like create political structures and social structures that build the world that we think about as, you know, civilization. So these then give rise to the social and structural determinants of health. So things like housing, education, income, racism. And, you know, and this next point has become so much more clear during COVID as a result of logistical supply challenges with PPE. All of this has to be functioning really, really well for us to be able to have a functioning hospital. And I did a lit review not long ago with Trevor Hancock, who's sort of a legend in planetary health, public health in Canada and internationally. And the best estimate we could come up with for the proportion of overall health that healthcare is responsible for is about 20%. And that's probably a slightly generous figure. So this is how I'd like to invite people to start looking at health. And this is what we would call a planetary health frame. And, you know, it's one of these situations where we had the luxury of kind of forgetting about a lot of this underpinning, particularly the ecological determinants, for a long time because it was just going well. And it's just simply not now. And so we emergently need to turn our attention to that, because not only do the ecological determinants have their own impacts individually on health, but really they need to be working for us to even be able to do the rest of our job. So this is a real quick tour through the health impacts of climate change. I live in one of the most rapidly warming places on Earth, and I serve a patient population because we're the home of the most northerly CT scanner in the middle part of northern Canada. So my patient population extends all the way up to the high Arctic. So in Nunavik, the Mackenzie River Delta, part of that is one of the most rapidly warming places in the world. It's 3 degrees Celsius warmer now for an 80-year-old elder than when they were born. So you can imagine what that feels like in terms of, you know, their ability to gather food on the land. Ice travel is much more dangerous. A given journey is less likely to yield a successful hunt. So there's a sort of a higher price for, gas as opposed to what you actually bring home. Leads to food security challenges, potential for trauma, cultural sharing practice changes, and mental health impacts. The word solastalgia, feeling homesick when you're still at home, was first described in some of these communities to describe, imagine being an elder where, lands or basically hillsides looked one way when they were little. And then with the permafrost melting, if permafrost gets exposed at the bottom of a slope, the entire landscape slope can cascade down to look like a mudslide. So when I speak with elders from the high Arctic, they tell me that when they were little, there weren't any landslides, and now they're everywhere. So you can imagine if all of a sudden your home looks entirely different, that you could feel homesick when you're still at home. And that's what solastalgia means. So this describes the immediate and direct risks to health from climate change, the indirect risks and risks associated with environmental refugee flows and conflict. So on the left there, these are the things we read about on the news. We've experienced increasingly ourselves. So heat waves, heat stress, heat stroke, deaths, drought, lack of access to water makes wildfires more likely. They have the potential for direct trauma, evacuation, PTSD, send big clouds of smoke up into the air, cause breathing, respiratory problems, often increase actual overall asthma rates in a given city, sometimes even cardiovascular impact. Storms lead to increased precipitation, floods, trauma, evacuation, pollute sometimes clean drinking water. And all of these can lead to, various sequelae. So increased temperatures are leading to longer and more severe pollen seasons, which makes it difficult for people who suffer from allergies. And we're seeing increased conversion of precursors to ground level ozone with the increasing temperatures, which worsens air pollution. So all of this is being driven by an increase in various greenhouse gases, including CO2. And we know from looking at blood gases that CO2, if in air, will equilibrate. Well, we know that from basic chemistry with the water underneath, and that when that's in a liquid, it acts like an acid. So humans don't like it when we get more acidic, neither do fish or other, aquatic species. And that's a bad problem because about 1 billion people in the world depend on protein from the ocean as their main source of protein. So all of this weird weather does bad things to crop yield, as we saw in that first picture, and deaths from malnutrition are thought to be the number one potential health problem stemming from climate change this century. So I spent about 6 months resuscitating infants with malnutrition with Doctors Without Borders, and I never had a child die under my care prior to that. And that experience changed what I do, and is really a lot of the fire of what drives what I do now, because I realized that with Canada having one of the highest per capita carbon footprints in the world, if I really wanted to impact those deaths overseas, really I should probably stay home and work on our carbon footprint. So you can imagine if your kid didn't have food, you'd almost do anything to find them food. So you could go to a different place. They might not like it that you came. So population displacement is a huge increased stress. It's really tough to get numbers on this. One of the great privileges of my life was I was able to coordinate the first policy brief between Doctors Without Borders and the Lancet Countdown on Climate Change and Health. And so certainly speaking with humanitarians from all around the world who are seeing these things on the ground, attribution science for all of those is not easy. Often there's overlapping factors, but people are extremely worried. And so, the potential for increasing conflict and war, there's thoughts that the war in Syria, one of the contributing factors was a 5-year-long climate-enhanced drought that led to rural to urban population displacement. And so there was a displaced population in the urban centers when it was met by the spark of the Arab Spring. So as sea levels rise, this is going to worsen. And really, the potential here is for a cycle of badness leading to systemic and economic collapse. And this is why I'm so popular at cocktail parties. Everybody loves me. They're like, Courtney, can you come back? But really, I think it's important to get to the diagnosis properly. And we're in a super critical time window. So there's 2 things you need to know. Number 1, we have 2 sprints. First sprint is an adaptation sprint. So that means we need to prepare for the impacts we can no longer avoid. And that's because the greenhouse gases that are already built up in our atmosphere haven't yet caused the impacts that they're going to cause inevitably. So the Canada's Changing Climate Report shows that even using a new baseline, in 1986 to 2005 baseline, we're going to see 2 degrees Celsius of additional warming from that baseline by the time, by about 2040. So that is not very long from now. So that means we are going to see more wildfires. We're not at a new normal for wildfires. We're going to see more. We need to make sure our ORs have really good ventilation. We're going to see more heat. We need to prepare our vulnerable elderly, have, check-in problems, cooling shelters. We need to really plan very concretely for this. And, this is a little dude who was born last year. So he's only going to be, 22 then. And now what happens if we don't get onto a low emissions pathway? So we're going to see that temperature almost irregardless of our emissions right now. But what happens after that is why our second sprint is to decrease greenhouse gas emissions emergently. And so we essentially want to stay on the blue line there to the latter part of the century. Right now we're tracking the red line. If we continue to track the red line, we're going to see 6.3 degrees Celsius more warming in Canada. That's because we're warming at double the global rate. Up here where I live, we're warming at triple the global rate. So this is the numbers for Canada as a nation. So if we continue to track along the red line, by 2080, Matthias is only going to be 63. These are the kids that we're seeing in our emergency department for bronchiolitis right now. Okay, these little people, they're only going to be 60, in the early 60s. And, everybody has a different way of describing what this means. But, Nick Watts, who's the head of the Lancet Countdown last year, was asked, and he said, well, we don't know exactly what it means, but it's going to be catastrophic. It's going to look a lot like the world looks right now, this feeling of instability, a real lack of control in various areas, disrupted supply lines. And we're just going to see crisis after crisis after crisis. And instead of being where we are now, where we had a full kitty, where we can, access that for our stimulus funds, that kitty, we won't have the opportunity to replenish that every time. So essentially, it will be a gradual sort of disintegration of our ability to cope. So you can see that, that's not okay. And so what I think is important, and I've been thinking about this a lot lately, I think that we are unconsciously a lot of the time operating with an information deficit model of change making. And it's really important that we start to move wholeheartedly towards a target-based model of change making. And we also have this unconscious sort of, feeling that the numbers are going to tell the story, but actually they don't. So Matthias was in there for a reason, because when you tell a story, we know that the numbers stick better. And we also need to get better at telling our wins. So it was really great when some people were telling us earlier about the accomplishments they've had, because then that becomes a case study that is inspiring to people. And then we could try to replicate that. That gives hope. We know that it's really emotions that move people to act. And we also know that teams are super important. And so deliberately creating teams to enhance that sense of solidarity, which decreases the courage required to do the work. And making sure those teams choose their targets strategically based on the evidence and based on the situation at hand. And so I just want to show you some things that Emerge Docs in Canada have already done. So Eric Nobalt, he's a CAEP board member. He has been working on cycling paths in Montreal. So you can imagine, switching from cars onto bikes decreases greenhouse gas emissions, decreases local air pollution. Cycling itself reduces mortality. I mean, this is the best thing you could possibly do for your health, for the world. And he got the mayor of Montreal to commit to doubling the number of bike lanes. And I was like, Eric, how did you do it? And he's like, il faut être incontournable. And I was like, what's that mean? And he says, unavoidable. You have to be unavoidable. So they created some studies with students, engineering students. They mapped the most dangerous intersections in Montreal. They came up with a proposal. They had policy materials, they started taking it to all the council meetings, and they were just there every single time. So after a little while, people were just like, oh, hi, Eric, and they knew what he was there for, and they got the job done. And actually now they've been commissioned to do these same studies for 4 or 5 different cities in Quebec. Coal phase out is something we can be really proud of in Canada. So the Ontario coal phase out, which was completed, was the first time that's been done worldwide in a major industrialized jurisdiction. It was the biggest single reduction in greenhouse gas emissions in North America from any single policy, and it's led to decreased air pollution related morbidity in Toronto. So how do we get this done? This is something that always feels totally goofy to me, but it matters that we're docs. This is one of the privileges we have, is that we rate really, really highly on the trusted messenger survey results. And so when you think about the fact, what's going to move people to change, some of it's the data, some of it's the story, some of it's who's telling the story. So because we have that privilege, we have a real responsibility to be some of the people telling the story. And at that point, we need to think about our audience and how we're going to indicate to them who we are. And every communication specialist I've ever spoken with has said to wear your scrubs on TV. And so this is my friend Joe, who's fantastic at wearing his scrubs on TV. It always feels, you feel like an idiot. But if you're walking past the, the video at I was about to say an airport, which may not happen ever again, it feels like, but you'll know exactly who he is. So it frames the message. This allowed, speaking of wins, this allowed us, our phase out, allowed our government to co-found something called the Powering Past Coal Alliance with the UK, who was doing something similar. And it was actually based on the health argument that they were able to do that, which meant that they could then sort of create a club for nations that has demonstrably changed approach internationally. So I was, extremely honored to speak, to represent the voice of health at the announcement for this at the International Climate Change Negotiation on behalf of Canada, with members of my patient population at the tables. So Bill Erasmus, who was the chief of the Dene Nation, and Francois Paulette were both there at the time. And I was asked recently for a book, what was the moment of my life that most made me feel like I was doing my job as a doctor? And this was the moment I talked about, because this is a moment of clear relevance to my patient population. I felt like I was bringing the stories from the bedside to the biggest table in the world at that point on this issue, and with members of my patient population there. I mean, it was just an incredible blessing. And I want us to really broaden our view of advocacy to consider where decisions are actually made. And it's really clearer right now just because we're seeing where the money is getting spent. Parliament being there matters. When I think about what I have to do as an advocate to get a meeting with the health minister, I'll make write something extremely evidence-based over the course of weeks. I'll spend months getting other allies together to sign on, and then we'll, get maybe 1 meeting or 2 meetings a year. Meanwhile, we had a leaked memo at CAEP from the Canadian Association of Petroleum Producers to the federal cabinet about a month ago, and it described 30 meetings that they'd had over the course of a month. So essentially right now, we don't have money. Nobody that I know of in civil society has money to pay for that kind of lobbying power. So, we need to think about, well, maybe we need to move with our feet into different spaces like Parliament. And so Minister of Health, former Minister of Health, Jane Philpott, her story gets told as though it wasn't a success. But when you look at what she accomplished, it was incredible. One of the huge things she doesn't get enough, I don't think she gets enough credit for, is our food guide. So our new food guide, she put up her elbows and said, no, you're not doing this process with closed door meetings with industry. We ended up with the most evidence-based food guide that almost exists anywhere on the planet. This was Minister McKenna's chief of staff and Dr. Brent Logan of EAT, who was one of the scientific authors on the EAT Lancet Commission, checking out their draft food guides about 2 weeks before they were each launched at the International Climate Change Negotiation, and they looked exactly the same. So, I mean, this is because of Jane Philpott. As my friend in the US says, in my country, ketchup is still a vegetable. So, you know, running for office matters. And so I just, thinking about solidarity in this moment in time, pretty much everybody feels like basically our society has been disrupted. It's like a Lego structure, toddlers come in, everything's on the ground. We have to put it back together in a low carbon way. We don't have enough time in the time window to do it once and then another way, and we don't have enough money in the kitty to do it, back to the way it was. And then again, we have to, our only option for health and safety moving forward this century for our little ones is to rebuild in a healthy way. And so one of the roles I have is that I'm the head of advocacy for the WHO Civil Society Working Group on Climate Change and Health. And so we created a sign-on letter with the help of the WHO and Christina Figueres' organization, asking G20 leaders to target a low carbon recovery as the path to health and safety to prevent further crises. And we managed to get sign-on from 2/3 organizations representing 2/3 of the world's healthcare professionals, including Canadian Medical Association, Canadian Nurses Association, and both colleges. So everybody here is represented in this, calling for a healthy recovery. And my call to action right now is, I know everybody's at a time of transition. We're all at a different place in terms of fighting COVID. But if you have any advocacy time, any time to learn some new skills, we need to put on a huge push right now, because I don't think we get a second chance at this. So this is CODA Change. They're the new SMAC. I was there, sort of am still their policy director. Everything got a little bit disrupted because of climate, but we're putting together a list of action items to sort of further detail what a healthy recovery means. And really the bottom line is act together and we will all win and keep one another safe. So thank you very much. And I will stop my screen share.
So I want to ask you one question, because well, first of all, COVID has taken over everything. And, 5 months ago, the only thing that we were concerned about was the Australian wildfires. And we've forgotten about those, right? Like the news cycle is so insane and it's so fast and furious. So how do you keep your message about climate change front and center? Like we've sort of forgotten about climate change. We've gone, okay, well, good, we're not flying anymore, so it's fixed. I'm curious to know what your organizations have been doing in the background during this COVID crisis to kind of keep it a little bit on the radar.
Yeah, so I think it's important that we recognize that COVID is a planetary health emergency as well. So it started with a zoonotic virus. So this virus started in animals and it ended up in humans. And that's exactly what we're going to see more of as the climate changes, as we destroy habitat, as the climate changes and we see, animals in different places. So it's novel interactions between humans and animals that drive zoonotic sourced pandemics. So this is not, in my mind, this actually isn't a competing priority. This is a proof point. This is like exactly what we've been worried about. And so now we need to take ourselves to a different path. And so I've actually done quite a lot of media around that over the last little while. And there's quite a lot of interest. Interestingly, everybody's looking for a bright side. So for instance, I have an interview tomorrow morning we've seen a 17% drop in emissions over the course of the early part of 2020 as compared to last year. And a lot of places are seeing clean skies for the first time and are feeling what that means. And they're seeing the mountain range on the horizon, which they haven't. And so for me, what those are, sometimes what we've had trouble doing as a climate community is helping people envision where we're going. We've been so preoccupied with it's going to be horrible that we've done a really bad job of being like, and this is what that world is going to look like. And so now in so many parts of India and parts of China, they've seen what that world can look like and what it can feel like to go outside and not feel horrible and start coughing. And so they have an embodied experience now that we can harness to help them envision where we're going as we're putting these policies forward. And so, we've shown that we can change the world really quickly when we act together. We've shown that it feels way better when our skies are cleaner. We've shown that crisis sucks. And so our message right now is we need to solve climate and COVID at the same time. And this is the path to health and safety. And this is what will feel better when we're there.
Right. Well, it definitely seems like there's more birds around. I will say that, even in our little town where we don't have much urban smog. I want to give the floor to Blair to give his presentation, because I think this ties nicely into the idea of how we use media, how we get our message out there, and how we keep attention on something as important as climate change in the midst of our COVID planetary crisis. So,
absolutely. And like Courtney said, if you can tie something into what's going on right now that's maybe a bit counterintuitive, like that COVID could actually be a good thing, it's certainly a way to get your issue in front of the media. First of all, I just want to acknowledge how absolutely honored I am to be hanging out with all of you tonight and on this panel of insanely talented and brilliant advocates. And so I'm just so happy to be here. And tonight I'm going to talk about very briefly the theme of fire and ice. And we'll get into that more. But first of all, I ask a lot of people, hey, are you a health advocate? And they all say, oh yeah, of course I'm a health advocate. And so I think a lot of people want to be good at telling the stories of their patients and the stories of our system, but we're not naturally inclined to do that. We're actually pretty bad at telling stories. And that's because we use this very unique scientific medical language that is not accessible to everybody. And so I think we're doing the right thing. I think we want to be advocates, but I'm not convinced that we're doing that thing right. And I'll give you the example here of these two people. When I was just hitting the ground on the ambulances, the SARS outbreak was happening in 2003. Mel Lastman was the mayor of my city, Toronto, and he got up to the podium, and this is a still shot, but you can probably get the impression that maybe he wasn't the most calming person to put in front of the cameras. I think Sheila Bazar, the medical officer of health at the time, she's on the left there. Her facial expression kind of gives you an idea that Mel maybe isn't doing a great job. But then Sheila took the podium, and she was just able to calm the entire city down. And she walked us through that SARS epidemic. And I remember how powerful she was as a communicator. I think that's a really great example of why doctors need to be great at communicating, not just our own language, but in a more common language. Now, there's a lot of bad communication out there and miscommunication. And I'm not going to spend much time on this slide, but there's a lot of wrongness going on in this pandemic and previously. There's misinformation, which is unintentional. There's disinformation, where people intentionally manipulate. And then there's malinformation, where people actually spread false information to cause harm. And that may sound a little bit far-fetched, but we know that there are intelligence agencies and there are organizations out there that have actually weaponized disinformation specific to health. And so this is something that we need to be aware of, and we need to be aware that there's a lot of icy thoughts out there. And when we talk about the typical misinformation campaign, it usually centers around the anti-vaccine movement, but that's just the tip of the iceberg. There are myths, there are rumors, there are lies out there around people's health that are being spread by people who might not appear to be ill-willed. Gwyneth Paltrow has all sorts of crazy ideas that not only waste people's money, but can actually harm their health. And it's kind of getting to a tipping point here. Americans trust medical leaders less than at any point in the last century, only 34%. When asked if you consider doctors trustworthy, people kind of go, meh, they don't agree or disagree. That's worrisome. And Canadians, 45% of them believe at least one COVID conspiracy theory, whether it's 5G or whether it's drinking bleach or whatnot. That's almost half. So we have a big problem here. And that's because it's not just doctors who are spreading information. It's other people as well who just aren't expert, but they're really good at communicating. They're better than us. And so they're stealing the limelight, and people are following them instead of our guidance. So basically, this boils down to a misinformation campaign that the World Health Organization has called an infodemic. It mirrors the pandemic. Misinformation actually spreads faster and farther than COVID. And it similarly leads to increased cases. You can actually track, as misinformation becomes more common, cases go up. So what we have is a national emergency. We have a crisis going on right now that demands our full attention and effort. And that's because lies are like C. diff. If you have a healthy gut and a good immune system, C. diff can't really find a place to live. But if you've recently taken antibiotics or had chemotherapy, those lies can just take hold, and the next thing you know, you've got C. diff. And so when you have experts being quiet, those loud voices that are wrong can fill the space. And so we need to fight fire with fire. And so my solution, my proposal is that we all have formal training in storytelling, and that we do that through the popular press, because that's where everybody else is playing. We need to go to the battlefield here. And of course, I'm biased as a journalist, but I think that battlefield is in the public sphere, in the media, online, digital, radio, newspapers. And the reason that's so effective is because there are more cell phones than people on Earth, and people go to their cell phones for news. So let's talk about what makes a story. Two important things. You have to have people. People are not data. They're not p-values. They're not cohorts. They're actual human beings. And stuff has to happen to them. You'd be amazed at how many doctors pitch me stories where nothing's actually happening. That makes for a really boring line. And of course, in a pandemic, I have this one infectious disease doctor who says, man, this is so easy. I'm getting called by every reporter in the country. I'm like, yeah, buddy, it's like summer and you're selling lemonade. There's a pandemic. Infectious disease doctors are experts at pandemics. And so all of the reporters want to talk to them. But what happens when it's winter time and you're trying to sell your lemonade? How do you get their attention? Well, here's what makes news. And I'm going to go through this very briefly. In the interest of time, but I really want you to take away this slide. This is a slide that you want to grab a screenshot of and remember carefully, because believe it or not, doctors, when they talk about news stories, they tend to miss these 5 elements. And the first is that it has to be timely. That means it has to be related to other stuff going on in the world that people care about. My biggest story ever was actually on pneumothoraces, which sounds super boring. And it was all because this girl went to a One Direction concert. She screamed, she was having a really good time in the mosh pit, and she got a pneumothorax. And so everybody wanted to know, hey, can you scream so hard at One Direction that you actually blow your lungs out? Which is a phenomenally stupid question, and I hated doing this story, but it was timely. And so if you were doing your PhD in pneumothoraces, like that was your moment to shine. Next up is it has to be important or weird or counterintuitive. And this is, again, where doctors tend not to hit the mark because we think everything's important to us because it's our field. But we need to learn how to make it interesting to the guy who works for Scotiabank, who's taking the train into work, or the school teacher who's driving on the highway into work. What makes that important or counterintuitive to them? What makes them look at that link on their phone and go, oh, I'll click on that. I'll dedicate my time to that. The next thing we need to do is make sure that we have lots of tension and debate. We have to show both sides of the story. We have to show what's going on that's maybe wrong. This is where our public relations colleagues and us might differ because they're always looking to keep their organization in a positive light. But sometimes there are just negative things that need to be spoken about. All of you are really privileged to have access to these stories because of where you work and what goes on day to day in your lives. You know these stories before journalists do, and so you are important partners with the media. And then making sure that something is underreported. And this is where, again, we come in handy because we know what's happening before other people do. So to have news, you need to have a story where stuff happens to people, and you have to have a hook, something that makes somebody wants to click on their story. And you would think that this quote might come from a journalist, but it actually comes from Osler, who said, always note and record the unusual, publish it. Such communications are always of value. And here's another doctor, a writer, Dr. Seuss. And Dr. Seuss wrote one of my favorite books, The Lorax. And in The Lorax, the main character there says, I speak for the trees, for the trees have no tongues. And that's what advocacy means to me. And if we want to speak on behalf of others, we need to make sure that we're heard. And I think one of the easiest ways to do that is to partner with the media, because they certainly have the audience that we want. So that's my quick talk on fire and ice, the infodemic and COVID-19 and how we can move forward with it. And I'll thank you very much. And if you're interested in more details, we're doing a workshop on how to get the media's attention at McMaster. You can go to that website there and join us on the 15th of June. Thank you so much.
So I think a timely hook on how to get your message out. And I suspect Courtney's favorite book might also be The Lorax, but I don't know for sure. I'd just like to wrap up tonight by giving everybody just one more minute to answer the question, what do you want Canadian emergency physicians to do tomorrow? So what's your big wish for Canadian emergency physicians that we can do that will help your particular angle? And I want to start with Lisa.
I want you to really think about what you're doing in your practice to advance and support the well-being of Black and Indigenous peoples, whether you're seeing them as patients, whether you're teaching them as an educator, or whether you're supporting and mentoring them in their development as leaders in our organizations. Miigwech.
Carolyn, your thoughts, your one wish for Canadian emergency physicians tomorrow.
I want them on their next shift to, every time they take a deep breath based on a person's name or their chief complaint, if they take a deep breath because they aren't really excited about going in, to take a moment, check their implicit bias and why it is they took that deep breath, and to go in with a fresh mind and see what they learn from that experience of looking within first.
Great. Courtney.
I want them first to take a big, beautiful breath and look around as they're outside on their way going to their shift and just realize how good it feels. And then when they're in their shift, I'd like them, when they're holding a piece of equipment, whether it's a syringe or what have you, this has happened to me a lot with a syringe. And just think about everything that needed to go right for that to end up in your hand. And to truly recognize that if we want to be able to pass this profession and everything we've learned over to the next generation and the generation after that, we need to take care of the ecological underpinning that makes it all possible. And we need to start that now. And so to support healthy recovery efforts, whether it's with time, whether it's with money, whether it's with solidarity and just emails to partners that you can see are trying hard, and that's what I'd like you to do.
Great. And Blair, last word to you.
The next time you read a news story or see a news clip on TV or see something on your phone written by a journalist, I just want you to look at the journalist's name and just start to get to know the journalists writing about healthcare in Canada. Most of you will know Andre Picard, but you might not know a lot of others. But I think that journalists have saved more lives in this pandemic than physicians by getting the word out and communicating clearly and concisely in a way that was authentic and trustworthy. And so journalists in Canada are our friends and our partners, and let's get to know them.
Well, I think that's a great final few ideas from some really interesting people and some advocates across our country. I'd like to thank CAEP for the opportunity to host our first National Grand Rounds. And if people want to continue the conversation, the hashtag CAEP Grand Rounds is active on Twitter. Happy to continue talking about all of these issues, and keep safe in our COVID world. Thank you.